This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thanks, Simon. I think you're going to be interested today because we're comparing three different ways of doing a MET system in the ED with early warning systems, multiple track and trigger, and as I'm about to show you, we've just chosen one vital sign to use. And this is not showing up very well, so you can't see the top. But we chose a single vital sign to implement as a MET when we started 5 years ago. When we were evaluating adverse events, as everyone else does, we looked through, and although we found tachypnea didn't show up as coming up in our adverse event patients, because generally the staff are pretty aware to it, and also the patients don't sit there and just huff and puff. They let you know that they can't breathe and that they're drowning. Tachycardia, we thought, was just not sensitive enough, and people can have tachycardia for a host of reasons, and I think some of the data that Julie showed, it wasn't a strong predictor, but our clinical experience sort of matches with the data that hypotension can often be silent, can be ignored, and we wondered if it was a killer. Just a bit of background data, I'll talk quickly about this. In trauma patients, the group in America looked at nearly a million patients, and they plotted mortality versus blood pressure in the ED. And they showed that clearly, and again, no surprise, that when you're hypotensive, your mortality was much higher. Graph at the top, I don't know if anyone can fix this. You're trying, okay. The graph at the top shows mortality for people with head injuries, and the one below shows mortality for people without head injuries. And as you can see, the mortality starts to rise as your blood pressure falls under 100. What about non-trauma patients? Again, data from about 10 years ago. This was about 5,000 admitted patients in the ED, so excluding all the patients who we sent home. Comparing people with hypotension and people without hypotension, and it showed that there was a clear difference in in-hospital mortality for people who had even just one episode of hypotension. As you can see there, it's graduated mortality rise from just transient one, episodic up and down a bit, and sustain where your blood pressure's under 100 the whole time. And again, sudden unexpected death was much higher for those groups. Looking specifically for sepsis patients, so there's a subgroup out of that, and although different authors, they looked at 800 patients with sepsis, again, looking at the mortality for patients who have hypotension in the ED. They excluded patients who were always hypotensive, those in septic shock. The people who had no hypotensive, or what they call non-sustained, so dipping below, getting treated, and rising back up again. And again, significant difference in hospital mortality. So we undertook to use hypotension as our ED MET vital sign. So it was just one thing, just a simple thing. Blood pressure under 90 would activate our ED MET. Again, we were using a bit of paper and a pen, and so people would write down the blood pressure, and then, depending on how well our education program was going, they'd alert someone to it, raise the MET team, which would be the doctor in charge of that area, the nurse in charge, as well as the treating doctor who would go and see the patient. We'd also get one of those lovely pink stickers put in the file as well, for our benefit, but also to highlight to the ward patients that they did have a patient who had an ED MET in the ED, because we think it's important that they know. We did a lot of audit at the start, a lot of education, did some audits, and again, this was paper-based. People would try and remember to put the sticker in the book, and we'd try and capture some data. We found that there were a lot less forms being filled in than we knew were hypotensive patients in the ED, and again, so that was a subset of the patients who had the MET called. There was also a lot of feedback about, why are you calling a MET on my patient? I know what I'm doing, kind of thing, because the nurses were, following the guidelines as they should, but some of the doctors felt it was a little harsh. However, and when we did our audits, the people were getting fairly simple interventions, IV fluids, some antibiotics, and I think only 10% of them were going to ICU afterwards. So most patients weren't all that unwell. But given that, we thought it was the right thing to do, and we'd persist and keep going, without actually knowing if MET is the right intervention for these patients. Because although the data showed that the patients are at higher risk, those studies don't say what to do if you identify that. we also found that patients, as has been mentioned before, staff might be rushing to these, 10 or 20, if you're getting so many of those MET calls during a shift, you might not be just doing what you're supposed to be doing. There's been studies published showing that trauma call activations adversely affect the outcome of people with acute coronary syndromes who are in the department at the same time. So you have to be careful about where you put your resources and make sure that you're getting the best bang for buck, if you like. So we thought, well, trauma calls, most people have got that fairly well sorted. We're not a major trauma centre anyway, but we have trauma calls and they generally get looked after fairly well. But sepsis is important, and we're a big medical hospital, so we see a lot of patients with both medical and surgical causes of sepsis. In terms of making a difference, this is a graph from, a table from a paper just showing the difference in mortality if you give people the right antibiotics or if you give them the wrong antibiotics. So the black line there shows that your mortality is your survival is about 10% if you get the wrong antibiotics. So you might as well just send them to palliative care ward. But if you give them the right antibiotics, they've got a chance of surviving about over half. The other thing that's important is getting the antibiotics early. Again, I presume a lot of people have seen this. This is just showing the mortality advantage of giving antibiotics early after the onset of hypotension. So down the bottom of the graph there is 0 to half and then half to 1 hour after the onset of hypotension. So a clear advantage in getting your antibiotics as long as they're the right ones. Given the feedback we've got from our staff and also trying to look at that data, we now don't go back through and look through every MET to see if it was recorded properly, activated, etc. We use MET as a plank to improve our management of sepsis patients to get people the highest chance of survival. We're still doing an overhead page to get the staff there, but having moved to an electronic system now, you can see there the little stethoscope in the yellow, the red box, the yellow highlight. It shows the patients who have had a blood pressure under 90 entered into their electronic OBS. So that highlights for everybody, and in particular the senior staff whose job it is to monitor the patients in their area. They can see that that patient qualifies for MET criteria and they need to go and do something about it. As I say, this is part of it's just one of the planks for improving our sepsis KPIs. We use that, as obviously everyone else will be using education guidelines, etc. And audit feedback is important for improving performance. So I just showed you how our performance has been going. Now, this is not all due to MET at all, but it's just, as I say, it's one of the ways that we're achieving our aims. This shows the proportion of patients who are getting antibiotics according to guideline. Obviously, we're aiming for 100%, and in the last year or so, we've been about 90 or 100%, which is obviously we're happy with that. The other important outcome is time to antibiotics after hypotension. And again, that's generally improved. Just so I'm not making up that data, I put in our last quarter was a bit of an outlier and quite high, which we'll look into. But again, generally on the improve. So again, like the Northern, ED-MET is just part of our ED now. It's normal, it gets announced, people go do their jobs. It's part of the electronic tracking system. I'd suggest to you that it should be incorporated into your clinical guidelines of whatever condition, etc., that you're treating or managing. And I was just thinking about it earlier. It's a bit like doing an ECG on everyone with chest pain. You apply this to everyone in the hope that you're going to achieve timely care for the people who really need it. So those septic shock patients, the ECG is for the STEMI patients. Thank you.